Today we are going to learn about peptic ulcers. Peptic ulcers, they occur in the stomach and the duodenal region of the GIT. Now, before studying the peptic ulcers, let us see the basic anatomy of the stomach. Basic anatomy of stomach. This is the stomach. Now you can see there are two curvatures. One is the lesser curvature and the second is the greater curvature. The stomach is divided into four parts. The first one is the cardia, the second one is the fundus, the third one is the body, and the fourth one is the pyloric antrum. At this point, there is pylorus. Pylorus is guarded by a pyloric sphincter. Next the pylorus comes the duodenum. This is the basic anatomy of the stomach. The wall of the stomach, it consists of four layers. The first one is serosa, second is muscularis, third is submucosa, and the last one is mucosa. This is the histology of the stomach. Now we'll see each part in detail. Now this is your stomach. Now we'll see how the wall is divided into four layers. This is the stomach wall. Okay, the upper portion is the mucosa. The mucosa contains most of the cells which are responsible for secretion of gastric juices and the mucin. Next part is your submucosa. Small blood vessels, they are scattered into this layer. Next comes the muscularis, and lately comes the serosa. Inside the serosa, there are large blood vessels. Now we'll see a deeper look at the mucosa. The mucosal layer, it consists of number of cells. These are the parietal cells. Parietal cells are also called as oxyntic cells. They are responsible for production of HCl, intrinsic factor, which is responsible for absorption of vitamin B12, and parietal cells are also involved in synthesis and release of some blood group substances. Next is the chief cell. The chief cell is also called as peptic cell. Peptic cell is responsible for secretion of pepsin in the gastric juice. This is the endocrine cell. Inside the mucosa, there are mucin secreting cells. The gastric juice contains HCl, pepsin, mucin, and electrolytes like sodium, potassium, bicarbonate, chlorides, etc. The concentration of the HCl and mucin balance each other so as to protect the stomach lining from degrading effect of the HCl. The internal lining of the stomach is protected by the mucin from HCl. The peptic ulcers are the areas of degeneration and necrosis of gastrointestinal mucosa exposed to acid peptic secretions. A peptic ulcer is normally a round or oval sore where the lining of the stomach or duodenum has been eaten away by stomach acid and digestive juices. It nearly affects 10% of the population worldwide, and the number of persons which are suffering from peptic ulcer is increasing day by day because of the lifestyle changes. Ulcers can occur at any point in the alimentary tract, but most commonly peptic ulcers, they occur in the stomach and in the duodenum. These are the two places where there occurs peptic ulcers. The ratio is stomach to duodenum as 1:4. So there are more chances of peptic ulcers to occur in the duodenum as compared to the stomach. In either case, the if it is gastric ulcer or if it is duodenal ulcer, it can be of two types. Either it can be acute or it can be chronic. Now we'll take a look at acute ulcers. Acute ulcers are also called as stress ulcers. Inside the stomach, the acute ulcers, they are small, they are nearly less than 1 centimeter in diameter. They are either oval or circular in shape. There are a multiple number of small ulcers located at one place, and they are shallow and they do not invade the muscular layer. So we can say that acute ulcers, they are not so severe in most of the cases. Acute ulcers, they occur due to psychological stress. Also, they can occur due to physiological stress like shock, septicemia, severe trauma, extensive burns. And also it can occur due to drug intake and local irritants. Local irritants include alcohol, cigarette smoking, coffee, higher intake of coffee, higher intake of tea. In case of acute ulcers, the margins and the base, they may show some inflammatory reaction depending on the duration of the ulcers. The stress ulcers, they occur due to ischemic hypoxic injury, but there is normal production of SCL. The level of SCL is normal. It can occur due to depletion of gastric mucus barrier, making mucosa susceptible to attack by the SCL. There might occur complications such as hemorrhage and perforations, but these are um, rarely. These occur rarely. The ulcers commonly heal by complete reepithelialization without leaving any scar. Now we'll take a look at chronic peptic ulcers. These occur either in the gastric, that is stomach, or in the duodenum. Depending on the area where it occurs, the ulcers which occur in the stomach are called as gastric ulcers, and the ulcers which occur in the duodenum, they are called as duodenal ulcers. Commonly it occurs in industrialized and civilized world due to the changing lifestyle habits, changing eating habits. It's also it occurs in the middle aged adults, and it is more common in males. The chronic peptic ulcers, they are almost about 1 to 2.5 centimeter in diameter. They're round to oval, and characteristically they are punched out. They are inflamed, elevated about the over the surface. Peptic ulcers basically appear at 2 points, as I have told you already, in the stomach and the duodenum. In the stomach, the gastric ulcers are found predominantly along the lesser curvature, because at this lesser curvature, the content of the gastric content resides for a long period of time. The duodenal ulcers, they are mostly found just beneath the pylorus sphincter. So we can say it occurs immediately post pyloric. It occurs in the first part of the duodenum. Now we'll take a look at the causes of peptic ulcers or the etiology. It occurs due to disturbance in normal protective mucosal barrier by acid pepsin, resulting in digestion of the mucosa. When the quantity and quality of the mucus is decreased, at that time the mucosal layer, it comes in contact with the acid. Even if your acid secretion is normal, not elevated, then also that acid, it can have a dangerous effect on the mucosa. The patients of the gastric ulcer have low to normal gastric acid secretions. The patient might have coexisting duodenal and gastric ulcers. There are chances that the person at one time, he might suffer from both duodenal and gastric ulcer. The etiology of it is multifactorial. Now we'll see the etiology. The major reason of duodenal ulcer is Helicobacter pylori infection. Helicobacter, it is a gram-negative bacteria, and it colonizes in the mucosa. Now, gastric ulcer, it cannot occur due to Helicobacter pylori, because this Helicobacter pylori bacteria, it cannot survive in the high acidic environment of the stomach. It gets degraded. So Helicobacter pylori infection causes duodenal ulcers, and this is one of the major reasons. The H. pylori bacteria, it releases adenosines, urease, protease, catalase, and phospholipase. The H. pylori infected mucosa, in return, it is going to release some pro-inflammatory cytokines. It includes IL-1, IL-6, IL-8. IL is interleukin, and tissue necrosis factor alpha. All of which they are released. All of these they are released in response to the substances which are released by the bacteria. These released substances, they initiate intense inflammatory reaction inside the mucosa, damaging the mucosal cell layer. It starts mostly in the antrum of the duodenum. It is very common in low income countries. The second most common cause is use of non-steroidal anti-inflammatory drugs, that is NSAIDs, because the non-steroidal anti-inflammatory drugs, they are inhibitors of the enzyme cyclooxygenase. Now cyclooxygenase is involved in the synthesis of inflammatory prostaglandins. This inflammatory prostaglandins, they protect the mucosal layer. So if there is no release of this prostaglandins, the gastric mucosa is rendered susceptible to the damage. And if someone has habit of using this NSAIDs regularly, then in such person it might start to develop ulcers. Other major reason is local irritants, which include coffee, cigarette smoking, spiced food, and alcohol. So pyloric antrum and lesser curvature, as I told you, they are exposed for a long time to these irritants. So in order to protect yourself from gastric ulcer, it is better way that you refrain from this local irritants. Other reasons are dietary factors, nutritional deficiencies can lead to peptic ulcers. Then psychological factors like fatigue, anxiety, and stress. These are also contributing factors for the development of ulcers. Genetic factors include blood group O people. They are at higher risk from suffering from peptic ulcers. Hormonal factors, Zollinger-Ellison syndrome. It is a tumor of the islet cells, and during this phase, the tumor is responsible for secretion of large amount of gastrin, gastric acid is secreted in high amount, and thus ultimately it damages the stomach mucosal layer. The next reason is acid pepsin secretion. It does not occur in the persons with Peyronie's anemia, as these patients, they lack the parietal cells. So we can say that the gastric secretion also plays some role in development of the peptic ulcers. And last reason is the gastritis. Now we'll see the pathogenesis. In the duodenal ulcers, they occur due to exposure of the mucosa to gastric acid and pepsin secretion. There is strong etiological association with H. pylori infection. The patients show rapid emptying of the stomach, so that the food which normally buffers and neutralizes the gastric acid passes into the small intestine, leaving the duodenal mucosa exposed to the aggressive action of the gastric acid. Also, there is generally hypersecretion of gastric acid into the fasting stomach at night. The gastric ulcers pathogenesis is mainly explained on the basis of impaired gastric mucosal defenses against acid pepsin secretion. The secretion level is normal here. The damaging influence is due to the factors such as gastritis, bile reflux, cigarette smoke, etc. There is depletion in the quantity as well as quality of the gastric mucosa. Now we'll take a look at complications. Acute ulcers, they heal without scarring and they are not so severe. So chances of complications are less in case of acute ulcers. But chronic ulcers, they are severe and they may result into complications. The first complication is obstruction. The long-standing duodenal ulcer near pylorus, when it starts to heal, it is going to show edema and scarring. Due to this edema and scarring, the passage of that near that pyloric sphincter, it gets reduced, and it obstructs the normal passage of the gastric contents. So whenever the patient, after eating food, when there is gastric emptying time, at that particular time the food, it cannot pass through that small passage, and hence such people, they experience pain. So these people, they are afraid of eating food. As there is obstruction to the normal passage of gastric contents, there occurs gastric obstruction near the, and it is also called as pyloric stenosis. You can see in the normal anatomy, the passage is wide, but during the pyloric stenosis, the pylorus is enlarged and the passage is narrowed. And due to this, the patient, he experiences nausea and vomiting. The second complication is hemorrhage. It occurs due to very deep ulcers. It is dangerous when there is artery nearby, because if this artery is damaged, it results into bleeding, which ultimately leads to hemorrhage in the GIT. If there is bleeding, or if there is a rapid loss of blood, that person, he might suffer from shock. There are two major risks associated, and these are: near the lesser curvature, there is left gastric artery. If that is damaged, then it might result into hemorrhage. And near the duodenum, near the gastrointestine, there is gastroduodenal artery. If these two arteries are damaged, then it leads to hemorrhage. This can be detected by testing the stools for occulted blood. Also, chronic blood loss may result in iron deficiency anemia, and severe bleeding may cause coffee ground vomitus or melena. Melena, it is coffee ground vomiting, and this color, it occurs due to digested blood. The third complication is perforation. Ulcer, it erodes the stomach or duodenal wall, and it is common in duodenum. Perforation, it allows undigested food to move to peritoneal cavity. Otherwise, the peritoneal cavity is sterile. When you have your stomach, if there is perforation, the food, it moves into the peritoneal cavity. Air escapes from the stomach and lies between the liver and the diaphragm. The air, it can pass through the perforation and resides below the liver, diaphragm, irritates phrenic nerve, and the pain, it goes up to the shoulder. Subphrenic abscess between the liver and the diaphragm may develop due to infection. Perforation may extend to involve the adjacent organs like the liver and the pancreas. Now we'll see the clinical features. Peptic ulcers, they are remitting and relapsing. Like once it is clear, it is not the thing that it is completely cured. The person in future, he might again suffer from peptic ulcer. So it is said that once a peptic ulcer patient is always a peptic ulcer patient. Gastric ulcer, we'll see a comparative of clinical features of gastric ulcer and duodenal ulcer. Gastric ulcers occurs in the 6th decade of life, whereas duodenal ulcers occur in the 5th decade of life. Occurs in labor class. Duodenal ulcers occurs in people facing more stress and strain. So we can say it occurs in the executive class. Gastric ulcers attack last for 2 to 6 weeks, whereas duodenal ulcers attack occurs by work, worry, and weather. Gastric ulcer, there is epigastric pain after having food, and there is no pain at night. Duodenal ulcer patients experience severe pain late at night and is relieved after having food. Mostly, these people are advised to go for a cup of milk, cold milk. Gastric ulcer patients, they experience vomiting, and this vomiting is relieved after this vomiting relieves the pain. In duodenal ulcer patients, there is no vomiting, they have heartburn and water brush, there is hematemesis and melena. Gastric ulcer patient is afraid to eat because after having food, the patient he is going to experience pain. Whereas duodenal ulcer patient, he have good appetite. There is weight loss in case of gastric ulcer patient, whereas in case of duodenal ulcer patient, there is weight gain. The weight loss is due to decreased appetite as the patient is afraid to eat because of the pain. Whereas in case of duodenal ulcer, the patient is having good appetite, and whenever there is pain, his pain is relieved by having food. So there automatically there is weight gain in such type of patients. Now we'll say diagnosis. Esophagogastroduodenoscopy. It is called. It is also mentioned as EGD. It is a form of endoscopy to detect location and severity of the ulcer. Diagnosis of Helicobacter pylori can be done by biopsy during EGD, breath testing, direct culture from an EGD biopsy specimen. It can be done by direct detection of urease activity in a biopsy specimen. Peptic ulcer perforation can be determined by the free gas in the peritoneal cavity using X-ray. Treatment for gastric ulcer is uh, the main treatment is to treat the underlying cause. If the major cause is H. pylori infection, then the patient is given some antibiotics and some acid lowering drugs like proton pump inhibitors. Sometimes the patient is given antacids. And thirdly, if there is severe perforations, severe ulcers, they are treated with surgery. Thank you.